If there is something missing, please feel free to tell us to correct. I know you're seeing this for the first time. Um, so what we did exactly in this duration was we took the AI notes, the content was transcribed, we used some GPT to process these and even create a presentation. Table number two's uh, representation is being done by Mr. Bala. And he's right now seeing this for the first time. But this is all done like right now in this 30 minutes window. And we are now going to see there would be mistakes. So human in loop, humans will be relevant and we would do our job after this. This is not the final thing. But like this, we'll consolidate for all 5 tables. We'll do our bit of policy analysts would sit through this. Next 1 week, 10 days, we'll actually make the final document and we'll share those findings back with you. Over to you, Bala sir.
Thank you. Yeah.
You can actually, yeah.
So okay. It definitely captures certain wrong things. My name got captured wrongly here. It should be A, not E. But at least whatever we have written on the sheets, it has captured to the core the best of the possibilities. So table number 2 is represented by P.J. Narayan sir, myself, Bala, Dr. Narendra Marishetty Garu, and N.J. Gauri Shankar. Okay. Okay. That need to be corrected. That's fine. So I believe there are several themes, but the intent of this particular table was more focusing on the clinical AI validation, and there is any kind of a shared liability framework, because if you're using AI into the ecosystem, what kind of a liability, who will own the liability if something goes wrong? So based on the deliberations and understanding, there is a lot of things we have deliberated. First of all, I just want to let you know, anything on the validation need to be done. I think Narendra Garu was saying about Manav principles need to be followed, and that embodies the thought of how human in the loop and human considerations need to be considered, and how the inclusivity need to be taken care of it. As part of that validation gates, now we have created 4 validation gates. So we were trying to look into the technical validation, which will allow us to look at the different elements of the hospitals to take care. Then you should use the local population data sets. If it is Telangana, it should be specific to Telangana. Then it will give you a kind of a demographic understanding how that particular thing need to be looked at. Then you do into third stage is about embedding into the workflow validation so that it is seamlessly working into your different hospital chains. It could be the EMR workflow, or it could be the surgery workflow or anything. The fourth important thing is about outcome validation. The entire thing of AI journey is to build the trust. That is also integral element of the validation, because once the trust is there, outcomes will be created because adoption will be high. This is the 4-stage validation which will reduce the risk as much as possible in the clinical way validation. That is what the intent we wanted to talk about. Coming to the liability space, there is I didn't have the papers, so I cannot cover, but whatever is there here, I will be able to give you. So there is a lot of stakeholders who are involved in this entire journey. It could be the technology companies or the vendors who are trying to develop the models for you. There is the hospitals who are trying to apply and use these models into their entire journey of thought. The third is about the clinicians who are leveraging these outputs or the decisions they are trying to make using these particular models. And the regulators who are trying to define the standards, enforce these particular compliances which need to be really looked at. And according to us, it's a shared liability. It cannot be owned by one single individual, indicating that you are liable for any wrong outcome. So hence, what we have defined is here as part of the outcome is vendor owns the model integrity as a liability. If anything related to the model drift happens or the model training is not there, and if that outcomes are not reliable, the vendor is owning it. Second is hospitals are also need to ensure that. It's again, they need to form the governance to before these models are getting deployed and productionized. The third important thing is clinicians who are depending on the different decisions. Even though AI is helping you in the compressed decision cycles, as we were deliberating, the judgment plays an important role. AI gives you a lot of information, a lot of data, but how you judge it. Human judgment plays a very important role looking into the data sets. And if their judgment goes wrong, they are also liable. Similarly, the regulator who is owning the standards need to also continuously look at whatever the tools which is getting deployed, whatever the systems are getting, they are really looked at it, and there is no oversight into it. The liability matrix is about the shared liability framework, what we wanted to define, so that it will really help that entire clinical tools which are getting deployed will have the real opportunity for the hospitals to look at. That's in a nutshell. I think there were several other questions. It has not been captured or something? Or am I missing something here?
So maybe this is not working because there are around 15 slides wherein we have got the inputs. So,
Okay, I think these are also coming in from the.
One second, I'll just give a little context. What we have done while we are capturing all of this, what you're seeing on this slide is the alignment with the different departments in India. So when we talk about Digital India and your inputs,
Okay.
the table inputs, how well they're aligned, the scoring is done basis the current information in the circulars and the news. We have done that context mapping and we have given the score. So National Cyber Security, NEP 2020 is something where there is a little bit of work which got missed while this set of documents came from the document, like from the table. But rest of the things that we are looking on where the score is green, those are the areas where there is a direct mapping. So what we are seeing coming from the table would be very relevant while we are drafting a policy, because there is a reference. Either the government is talking about something similar or they are seeking similar inputs. So your inputs would be very valid is what this particular screen is actually talking about. The direct fit across the national agenda is what we are looking into.
See, one important thing which I wanted to touch upon here is, probably it will help. So this is pretty good. I think it is capturing all the possible elements we have written down. Fantastic. I also want to advocate a thought as part of the policy is Telangana government need to have AI model registry. We have the sandbox, but AI model registry which will really capture what are the models in the healthcare domain are getting developed, used, can be commonly reused across the different hospitals. Otherwise, we may end up developing or duplicating the similar kind of a models. If the AI model registry exists, it is easy for us to discover, leverage, and keep on enhancing and moving forward. It could be a model number or model version number, model capabilities, model skills, what it offers, so that different departments in the hospitals will be able to leverage that. Creating one of the policy of creating a Telangana AI model registry would be, for the healthcare, will be powerful. That's one input. And responsible AI for all use case, very good. Okay, you have gone beyond Telangana also.
So our focus is not to just do state government policy. This will go to Niti Aayog because we have access to that. This will go to the central government for the health policies. So we are trying to look at what are the policies, similar policies, and what's the overlap. The recommendations which have been made, whether these are mapping to any other state government policies too, not just like the central or only Telangana. Because the recommendation documentation will go to pretty much all of these ministries and to the secretaries.
Fair. So it's about replicating the best practices across the different states. Okay, this is very nicely placed. The immediate action of setting up the clinical AI sandbox with regulatory ring fencing, this is what is needed. And the validation framework is also we have recommended, which will really help in the entire flow of thought. And liability matrix also, but I didn't aware of launch of the ambient documentation use case. Anything you have documented? The third point, launch the ambient documentation use case as the first low risk deployment. You want to comment on that? Okay. And most important, see, basically, the Telangana Clinical AI Sandbox with regulatory ring fencing is one of the important investment which should come from the government of Telangana, which can play a very important role for the primary health centers and also for the Basti Davakanas, which you are mentioning. There also it could play a very important role, how they can adopt and scale these things. And the validation and shared liability metrics will give the more responsibility and accountability for the people who are trying to leverage this. And creating a national risk-tiered clinical AI assurance standard is very, very critical. I believe our National AI Healthcare Mission, which we are trying to talk about, and also the National Medical Council will definitely, Medical Council will be responsible for doing that. But every tool, every model we try to deploy, it should follow the particular standards and the governance, and that will really create a good benchmark for us to take it forward. Fantastic. And scale indigenously is another important action item we have given. Okay, this is a 4-level clinical AI validation. I think this is coming from our input. Fantastic. Okay, these are the different entities. Okay, these are the 5 important entities or the stakeholders who are responsible for any kind of an integration need to be happening. And government plays a very important role in setting up the sandboxes. Industry plays a very important role as part of the integration. Startups can play a very important role to validate and bring that agility into the deployment as part of the compliance angles. Academia plays a very important role in validation and also the benchmarks, which clearly helps us. Investors who can really help in de-risking and help us to move from pilot to scale. All these things are part of the validation pipeline, and this all players have a significant role to play in this entire journey. And okay, this is a big numbers you have brought in. I don't think I have mentioned this, but this is coming out.
This is a research that we have actually pulled basis. So we have pulled some numbers basis the information that was provided.
Okay.
So that's the additional layer of prompts we have added to.
Fantastic. I think the aim startups with a clear, credible deployment pathway, 150 plus. Fantastic it is. I think that's a scale under which we are trying to operate. And the number of $25 to $30 billion is a potential health AI value add to play by 2035. That is also crucial. And okay, Telangana lead and 4 states can replicate these things. Fantastic. Launch a national pilot program anchored in Telangana's existing sandbox infrastructure. And also I'm trying to advocate, to add here is about create a Telangana healthcare AI model registry, which is currently not available, but that can make a big difference. Okay.
To your previous slide,
This
where
one?
the previous slide where you had validation by 5 different entities,
Yeah.
startups. I think you might want to include NGOs in the healthcare space. They are actually connected closer to the audience. But I'm also thinking here, are there any groups that represent patients themselves? Because we are seeing all entities that are delivering services, but
Correct.
nobody that's representing the patients themselves.
Very
What
good
are
input.
some of those entities that
Very
we can
good
think
input.
of to bring
Because
in?
they are the ultimate beneficiaries.
Indeed.
Their voice also plays a very important role in improving this entire validation framework. No doubt about it. We should consider that. Both the entities which you mentioned about NGOs who are doing the voluntary services in the healthcare space and the patient, these 2 voices are also critical for improving this. But the way we have integrated this validation pipeline is, this is something before touching the patient, people are trying to use this as a pipeline to validate and put into the deployment. This is before deployment. NGOs and the patients will come post-deployment to voice the feedback. But anyway, as part of the feedback loop, they are also very important entities. Very, very important entities.
So in this, here, table 4.
Okay, sorry.
So you are talking about that implementation model, national pilot program, some
Correct.
things like that. You see that when you look at it from a implementation perspective, if you have a national pilot program, it is good to have one representative from state when you're doing this pilot program or in the committee itself, because they are also in the game. So
Correct.
in case implementation of your pilot will be easier in the other states when you have representation from other states. So you should write to those states and take one representative so that once your pilot is done, it's very easily replicable.
Agreed. Involving the other state members as part of the pilot program gives more confidence.
One
to the
person at
one
least.
person.
One person.
so they can see the live implementation of the pilot, and they can be the ambassadors to voice the opinion in their state governments accordingly. Fair point. Okay, this is a very important statement we want to define: validate before the rollout. That is very, very critical and important for any kind of a service or any kind of a solution. But co-creating with the clinician is very critical, because this is where we don't want to do the things in isolation, but work with the clinicians so that we have the right input coming in, and so that it can be really validated with minimum liability, with a minimal risk. We'll be able to achieve the objective what we want.
Great, I think that's it that we have for this presentation.
So I thank Sriram, Sridhar, and your backend team for putting up this wonderful presentation in a short window, capturing our inputs. Kudos to them. Thank you.
Thanks a lot, sir. We are just pulling a presentation for table 1. If you can nominate one representative from your table to quickly talk through.